of suggestions to cover issues that revolve around misdiagnosis. So one, I'm going to talk about diagnostic overshadowing, and I'm going to talk about a related topic, which is where a lead symptom winds up becoming a diagnosis, or in other words, where a lead symptom can lead to a diagnosis that may be wrong. But more on that next time. But today we're going to focus on diagnostic overshadowing, which is, roughly speaking, the process whereby a correct diagnosis might be missed because clinicians see a psychiatric diagnosis and then think that the symptom in question is related to the psychiatric diagnosis. So the diagnosis, like schizophrenia, for example, would overshadow other things and lead to misattribution of symptoms. So let me give you a real-life example from my own work. I was a little blown away when I wound up getting this case. I actually became the consultant for the 61-year-old man. The man in question, it was noted from the beginning of his hospital record when he showed up to the emergency department of an academic medical center. This is a 61-year-old man with a long-standing history of schizoaffective disorder. So right there you see, I think, the setup for possible overshadowing. Lead sentence, he has a severe mental illness. He showed up to the emergency department, actually after his wife called the advice nurse, due to concerns about 3 days in which sedation was present and seemed to be increasing with each day. And it was also noted that just prior to the onset of this progressively severe sedation, he had started metformin, which for him was a brand new medication. His primary care doctor and he had been watching hemoglobin A1C and glucose, and at some point they decided now is the time to start metformin. So when I did the consult for this guy at a couple weeks later, he told me, I waited until a Friday to start this medicine because I have a job and I didn't want it having any chance of it getting in the way. Anyway, so this was the initial complaint. Let's look at the physical findings from the emergency department report. Essentially normal. He had, according to the records, normal physical exam findings. They did do some labs, including a basic chemistry, which showed normal glucose level, normal electrolytes, and normal anion gap. They also did an EKG. There were no chest or cardiac complaints. The EKG was I suppose it was just a routine order. I don't know. There was no documentation for why they ordered EKG. But it did show that there was a left bundle branch block, and that seemed to be a new finding compared to EKG recordings that were in the medical record at this medical center. So that was that. They did do some psychosocial history, and they asked, how have you been feeling? How's your mood? He described having a low mood. In the records, he never actually said the word depressed or depression, but he did talk about tension within the family because an adult daughter was having financial difficulties. He wanted to help her but couldn't, and she was not happy about that. So there was, in addition to both the patient having financial problems and the adult daughter having financial problems, they were arguing about what is the appropriate level of support from the father to the daughter. So there was that. Here's how the documentation went with the medical decision making. It was noted briefly that the sedation did sort of coincide with the onset of a new medicine. But since glucose level was normal and there was no suggestion of acidosis, and also somebody actually said, I looked up the side effects of metformin in a side effect database. They couldn't find sedation listed as a side effect of metformin. So on those counts, the idea that the medicine was the cause of the symptom was ruled out. They then rendered a discharge diagnosis of exacerbation of depression in a man with schizoaffective disorder, with a plan that he increase his citalopram, that he continue the metformin. and then go and see Messamore in a week from now. Curiously and maddeningly, nobody commented about the new EKG abnormality, nor did they communicate that to his primary care doctor. So that was a little jaw-dropping for me. And anyway, to complete the story, patient shows up with his wife. Wife accompanied him to the emergency department, and I said, "So what did you do?" And wife said, "Well, we stopped giving him the metformin." And then what happened? Well, he started to wake up and get normal. So the correct diagnosis was, in my view, egregiously missed, and the symptoms were ascribed to his, to his long-standing diagnosis of schizoaffective disorder. So to come back to, this illustrates the process whereby physical symptoms or psychiatric or behavioral symptoms, in this case sedation, are incorrectly attributed to mental illness. And the problem with that is that had the patient followed the medical advice to the T, he would have increased the dose of medicine, which wasn't necessary, which, given his diagnosis of schizoaffective disorder, which was bipolar type, would have placed him at risk for having a manic episode, theoretically. And had he followed the advice to the T, he would have continued the metformin and would have either maintained, and the sedation would have continued or worsened. It wouldn't have solved the problem. And the consequences can be much worse, obviously. And this is an important and, for me, very bothersome topic because, as I think viewers of this lecture will know, that just like anybody else, people with mental illness can have physical illnesses. Some estimates say that half of people at any slice of time with a mental illness will have a physical condition. And according to a study by Zelneric, 35% of people with mental illness have medical illnesses that aren't known at this time. So certainly this is a group of individuals who deserves careful and close medical attention, but for a variety of reasons may not get it. And the consequences are profound. This could account for the observation that in the United States, if you have a diagnosis like schizophrenia, your lifespan will be decreased by between 10 and 25 years. So I know this audience is going to be doing the right thing, but I just want to point that out for, I guess, the world at large, that this is a thing. Why does this happen? In the case that I just explained to you, I happen to know all the clinicians that were involved, and I know them to be competent, caring, smart people. So I was really just dumbfounded how this group of very smart people could have come up with something that was just so wrong. And the only idea that, with every case that I'm referred that involves something like this, common factor seems to be inadequate time. So this patient showed up in a busy emergency department, had like several very brief interactions, and in the end, I think not a lot of time to consider the nuances of the case. So lack of time means lack of adequate assessment. It's also common when you have unusual or complicated presentations. So somebody with a mental illness who has a broken bone and say, "I think my arm is broken," will have obvious physical signs, and so nobody's going to miss that diagnosis. But if somebody with a mental illness comes in and says, "I feel strange in my body," or "I feel like I can't think well," or "I feel very sleepy," or "my leg hurts," that is a much broader differential. And if you can't find a obvious physical symptom or obvious physical sign, then it becomes easier for a clinician to wonder whether this is a manifestation of the mental illness. Many people that are affected by psychosis will have difficulties communicating in ways that are commonly understood. And for example, in one case in the literature, a patient was talking about his legs being under attack. And kudos to the doctors that listened and thought it through. He was actually describing claudication of his legs due to a vascular abnormality. So the leg, had he not had psychosis, he might have said, "I notice that every time I walk for a considerable distance, my legs start to hurt." But in his language, they were under attack. And in cases where patients may have agitation, where clinicians may be afraid of patients, this can lead to sort of a limited exam and a rush to ascribe or to prioritize mental illness symptoms. And sadly, clinicians come from the same population as everybody else, and there is a great deal of bias and stigma around severe mental illness, and clinicians are not immune from carrying that bias. So I try to look for estimates of the prevalence of misdiagnosis amongst people with established mental illness. Difficult to find. There are some data that say that we'll say covering around 10% of people with severe mental illness turn out on closer examination to have significant medical problems, which are either causing or exacerbating their symptoms. So it's a not insignificant problem. And nobody has come up with really fabulous ideas about how to stop it from happening. So pearls from the literature that also ring true with me are that it helps us start by always suspecting that within this clinical encounter you will find a physical illness that nobody else has. So if you have a high index of suspicion and give the benefit of the doubt to physical causes or so-called organic causes, you're more likely to not miss them. I think it's very helpful, and certainly there are many cases described where minor abnormalities like a small degree of anemia, when worked up, lead to medical diagnosis that can be very important. So my suggestion would be, if you see like a tad abnormal potassium or a small deviation from normal in red blood cell count, it certainly is worth it to try to understand the cause rather than just ascribing it to natural human variability. And it's also a very good idea to be aggressive at getting other information. In this particular case I described, the patient himself, recall I've met both the patient and his wife, the patient himself was a taciturn man. He had not a lot to say, and he had not a very giant vocabulary. His wife, though, was very attentive and very verbal, and had they listened to her for a while, I think that they probably would have gotten the right diagnosis within about 10 minutes. And it's also important to make sure that we maintain good cooperative, collaborative relationships between physical medicine clinicians and psychiatric medicine clinicians, and keep open minds on both sides of the table when symptoms arise that don't have explanations. Before you come to concluding it's psychiatric, consult with the psychiatric colleagues, and before a psychiatrist concludes there's nothing physically wrong, it certainly is worthwhile to run that by physical medicine colleagues as well. So those are some thoughts about diagnostic overshadowing. I will stop that. And let's go on to this. I'm hoping to